It's time to enhance the relationship between expertise and impact, between knowledge and application. Welcome to a journey of discovery and empowerment. Welcome to All Physicians Lead, the Forbes Books podcast that highlights the critical leadership role that all practicing physicians take on every day. Here's Dr. Leon Morse.
Owen Dahl brings over 40 years of transformative healthcare leadership, including roles as the CEO of a physician practice management company, as well as a 300-bed hospital. A respected author, educator, and speaker, his most recent book is titled Humanizing Lean Leadership in Healthcare. Owen, welcome to the podcast.
Well, thank you, Dr. Morse, for giving me this opportunity to share some time with you, our listeners, and hopefully to learn a little bit more from you.
Well, we're looking forward to the sharing of the knowledge and experience, and pretty excited to talk about your books and your work. Before we get down that trail specifically, though, just, it's always good for the listeners to find out a little bit about our guests and tell us a little bit about your journey, where you grew up, what you learned, how you made decisions that gave you the experience that we'll talk about today.
Well, again, thank you. And I hate to talk about myself. I think it's more important to hopefully share some knowledge and some quote unquote wisdom that we may have gained over the years of our experiences. But I actually started I graduated from Concordia College in Moorhead, Minnesota, with a degree in healthcare administration. I was the first graduating class in that program. Immediately became an administrator of a 30-bed hospital and a 30-bed nursing home in rural South Dakota. And then I got drafted. And so I spent some time in the Air Force. I didn't want to end up in the Vietnam Army scenario, so I took the easy way out and enlisted in the Air Force. And spent a few years in the military. Went back to that hospital. Then I went to Rapid City Regional Hospital in Rapid City, South Dakota, and moved up the chain to actually became the acting CEO there. And then things sort of evolved, moved to New Orleans from Rapid City, which was quite a environmental change, and ended up as a CEO of a hospital in New Orleans. But at the time, I didn't like the idea of having people in Southern California tell me how to run my hospital in Louisiana. One thing led to another, and I quit and started doing consulting and opened up a billing service and a management services organization. So for the last 42 years, I've been working more directly with physicians rather than being on the opposite side of the desk as a hospital administrator, always arguing with physicians. I was supporting physicians. As time evolved, from that perspective, I also had this management services organization in New Orleans, and there was a little incident about 19 years ago called Katrina that sort of got in the way. And what ended up happening is half of my clients, half of my employees, half of the patients, and so on were not available. And my wife is a tax attorney for a large electric utility company in Louisiana that serves several different states. They decided they wanted to move her to Texas. And so I said I can continue to try to rebuild my business in Louisiana, or I can move to Texas with my wife. So, within a split second, I moved to Texas. So for the last 18, 19 years, I've been doing independent consulting. And again, all of my focus has been within the physician environment. And most of my clients and most of my services that I've offered are not to the large corporate structures and so on. It's more to the smaller groups anywhere from one, not a group, but up to 25 or 30 or 40 different physicians. And so I've had some really wonderful opportunities to work with physicians in this concept of leadership and what can be done in terms of developing and maintaining and in growing the physician practices.
Well, that sounds awesome. I mean, thank you for all of that effort to ultimately take better care of our patients. That's why we're all
That's the
in
name of
this.
the game.
So
Yeah.
that type of collaboration, undoubtedly, and we'll talk about it more, is going to be very, very beneficial. Your most recent book on humanizing lean leadership. I'm fascinated by all three of those words put together. Congratulations on getting that out. Tell us a little bit about what that means and how you came upon that concept.
Well, thank you. Thank you for mentioning that. And that's been a growth pattern for me for the number of years because uh, when I advanced my fellowship in the American College of Healthcare Executives, which is the arm of the hospital world, uh, my paper, my topic, my thesis was on total quality management, and that was big by W. Edward Deming and Joseph Duran and some of those folks in the 1980s and so on. So I've always had this passion, and you just made the point that the whole point about our discussion and hopefully about what we've done in contributing to the world is to focus on the patient. And so focusing on the patient in the world of total quality management, what does that mean? Well, what are we doing to provide that quality service to those patients? And so over the years, I've kept that focus and uh, got into the concepts of lean and Six Sigma. And Lean and Six Sigma, when I mention that to physicians, they say, "Oh, I don't want to follow that. That's stuff that goes into the manufacturing world and has nothing to do with me and my medical practice. And what are you trying to tell me?" And yada, yada, yada. Well, Lean focuses on how efficient you are and in terms of what you do and focuses on how effective you are. So Lean looks at how you flow and how you manage the process of taking care of patients. And Six Sigma concepts look at what are the defects, what are the broken parts. So in that flow, if you have a bad prescription or you do a procedure on the wrong leg or whatever happens is a defect or you make, something like that happens, you take these principles and you move forward. Well, the principles really start out with what? Serving the customer. And so how do you serve the patient and what do you do in serving the patient? So you focus on that. And then the second component of it that's really critical is waste. And from the total quality management world, if you actually go to an office and start to talk to an employee and say, "Well, how much time do you waste every day?" And they're going to say, "Oh, I'm busy all day long." Yeah, well, you're busy, but are you moving a piece of paper from the left-hand side of the desk to the right-hand side of the desk? What are you doing that way? And statistically, it's about 25% of an individual's day that is wasted when you put it in the perspective of what are you doing looking at providing the service and the support for the patient. So the whole concept here is what do we do in terms of eliminating that waste to serve the customer? Well, you got to measure it. How much time does it take? So if we take the concept of the manufacturing world and look at Toyota, which is one of the big forerunners in the lean scenario, Toyota is a flow, is everything flows through in a cycle. And so when you're building a car, you go 1, 2, 3, 4, 5, 6, 7 steps. When you're seeing a patient in an office, a patient checks into the office. And by the way, this concept to me is whether it's a solo practice or a Cleveland Clinic type of practice, it's still the same. And so patient checks in, they get triaged with their vital signs and so on. Then they see the provider. Then there's some immediate activity after the provider, and then there's checkout. So there's 5 steps. Well, what is that? That's a flow, just like building a car. So tell me that the principles that Toyota have don't apply to that same concept of a flow. And so you can look at that way, or you can say, well, okay, I saw a patient, so I checked the box. It was a 99213 visit, and it gets billed, and so on. Well, that's a flow as well. Hiring an employee is a flow. And so when you put all that into perspective, where are there gaps? Where are there wasted? But I like to ask questions like, well, how much time does it take for an average patient to be seen in your office? From check-in, which is step one, to check out, which is basically step five in that cycle. I get answers anywhere from, 25 minutes to 3 hours.
That's not standardized.
No, it's not standardized at all, unless it's standardized for 3 hours in that one
For
office.
every patient in that
Yeah,
office, right? Yeah,
yeah.
exactly.
And so, but the point is that you need the metrics in order to do that. Because if you don't understand what that is, and then you don't break down those components in some fashion, you really don't know where your gaps are, where your barriers are, where your breakdowns are. And so you start out with the metric. It's the same thing with the defects. How many bad prescriptions do you write, or how many of this, or how many of that, that go on in a particular environment? What I tried to do with the book was to talk about lean and the concept of lean from a perspective of there is a process that's involved. There are tools that are involved. There's a lot of metrics that are involved to do that. But one of the key wastes that we have, and this really speaks to the whole idea of leadership, one of the key wastes that we have, don't engage an employee's brain. We tell the employee how to do something. We don't ask the employee, how can we do this better? How can we do this differently? What my concept was when I talked about humanizing was let's humanize, let's engage those employees in fixing this process. What are the things that we can do to engage them in coming up with better ways of making changes or improvements? And I don't like the word change. I like the word transition. How do we transition from doing it this way to that way? Because the word change implies, oh, I got to do something I don't like. It feels uncomfortable.
That's right. It's scary, right? I don't
Yeah.
want to change that.
So the idea is let's see what we could do to improve this process, to reduce that cycle time, to reduce our denial rates on our claims and things of that nature.
Yeah, that's great. I mean, bringing that human element in, there's a lot of brain power in our offices and, often a tremendous amount of experience. I mean, some folks may have been in our offices for 10, 12, 15 years and have seen different ways of doing things and can envision better ways of doing things. But if we're not asking them and engaging them, as you suggested, then we're never going to know that. So that's a very interesting point. As soon as you said, the biggest waste, I went to time, clearly. When you plot out the steps and you see all the idle time that a patient's walking through, but that puts a whole new spin on it when you talk about waste in terms of a missed opportunity to engage all of our teammates on how to run this system better. And that speaks to leadership. I mean, one of the things that we talk a lot about here is the idea of creating psychological safety so that a team member would be willing to, walk up to the doc or the head nurse and say, hey, here's a better way to do things. And they're not told, shut up and dribble, just do your job. I don't want to hear your input.
Right. Yeah, I think that's a really, really good point, and that speaks to the idea of building that leadership model. And as a leader, what do? You don't tell people; you engage people, and influence their behavior. Yes, and you set the tone with a good culture that allows you to do that. But by the same token, if you don't recognize the skill set that's there, and you're right, somebody's been there for 10 years, they've got a lot of knowledge about how this flows. They've got a lot of knowledge in terms of building relationships with patients and how patients can, patient A, patient B, patient C, what they need and so on. That really gets to the whole point of improving that patient experience and making that a valid and a viable option.
Yeah, because the pain points for the patient are, to put it in a pun, painfully obvious to the staff members, right, who are watching this happen. And, if they're allowed to speak up and suggest improvements, that's a huge enabler of better patient care, better patient experience. So good thought.
And when you think about today, every article I read, everything you research you do says that, well, all patient visits are 15 minutes. And, So we standardize everything at 15 minutes. Well, what can we do in that 15 minutes? Oh, we sit here at our keyboard and I do this, and I do that. I'm not really interacting with the patient. But how can we improve that? And sure, AI can make a big difference, but that's not the point here. The point is that if you've got a team of folks that are supporting that provider in in dealing with that patient experience, you can all work together to make that patient experience that much better. In terms of a good comprehensive interaction, it's just like you and I are interacting right now. We're looking at each other, even though it's by video.
Yeah.
Still looking, we're still interacting with each other. Pay attention to what we're saying, and how much of that really can occur in that 15-minute window without having a good understanding of what that patient need is at the time. And how do we get that? Well, we get that by working together and making things happen better.
Yeah, the number of distractions and draws of your mental energy and focus that occur in that 15 minutes. Where is that lab, and how come the x-rays aren't here, and the chart isn't pulling up on the screen properly, and I logged in with the wrong credentials. I got to get into a whole different chart, and by then you're 6 minutes in, to a 15-minute visit. You've had zero engagement with the patient, and the patient feels that.
Wow.
Right.
You just scared me when you went through that little litany there.
I went through our EMR, just sit down, log in when I walk in one time, and I was with a pediatric group, and it took me 3 minutes and 8 seconds and 146 keystrokes before the patient chart popped up in front of me. I said, guys, we got to do better than this.
It's amazing. How did you know to time it and to count the strokes?
Oh, well, I did it as a test. So I just sat at my desk and said, okay, watch this, team. This is what I do. I come in, I sit down. This is our computer. This is exactly what's in every exam room. Start a watch, and I was counting keystrokes, and that's what we came up with, and said, okay, well, we have to do better than that.
I commend you for that, because again, with the lean principle, what that means is you got that 3 minutes there. Now, if you can cut off 10% of that, okay, that's a little bit. But the idea is I can't fix that 3 minutes immediately for every visit, but I can do something called continuous process improvement, which means that I can fix a little bit now, then I can talk a little bit more to the staff, we could do a little, then I can fix a little bit more, and eventually I can get close. Because one of the principles that we have as a goal in the lean world is to be perfect. Well,
That's right.
We'll never be perfect.
It's very Zen-like, right? The pursuit of perfection, knowing that perfection cannot be achieved, but that's our vision, right?
Right. And in the Lean Six Sigma world, well, Six Sigma, what is that? That's pretty close to perfection. And so if we can get to that Six Sigma standard in that signing in and reducing your 146 keystrokes down to 15, we've cut 90% out of the problem. And so that's what the goal is in terms of what goes on. And that's why with Lean and Six Sigma, there are, you use flowcharts, you use process maps, but there are a number of other tools that are available to the participants to be able to do a lot more about how that all fits together. So what we like to talk about in what I wrote in the book is to talk more about these are the tools, but those tools are there for what? They're for you as an employee, as a leader, to be able to use, to apply to the you just described very well, and how we can then move forward with it.
No, and it's very beneficial. And we went through a process, as you described, that was fairly similar. It's like, okay, well, do we need this screen? And why do we have to log on twice? Why can't we do that once? You've already established my credentials in this setting, exactly as you suggested, just taking chunks off it sequentially over a couple of years. So brilliant. One of the things I want to take advantage of here is sort of melding our two experiences. And The all physicians lead concept is that you don't need a title. You don't need to be in a particular position within the organizational hierarchy as a physician to be a leader. That if you're influencing behavior to achieve a desired result, as I submit every physician is every day, then you are leading, whether you recognize it or not, whether you reflect on it or not, whether you try to get better at it or not. You have influence, you have impact on your team, the patients, families that you interact with. So with that context, you have a vast experience working with physicians. Do you think that most of the docs recognize that you've encountered recognize that they are leaders and that they have impact and that they, are aware of that? And B is, there are a range of that awareness. What are the, good, great experiences you've seen, not with CEOs and chief medical officers and department heads, but really frontline doctors who are leading every day?
Well, I can make 100 comments to that
Oh,
particular.
excellent. I'm taking notes as my next book.
But the word leadership doesn't enter into discussions with physicians that often. So to say to somebody you are a leader is like, what? I'm just the doctor. I'm just doing this. So I don't know that we could put it in that context, even though I really enjoyed your book and the points that you make about the leadership role that the physician has for me as a patient or for me as a team member. And so there's really several different perspectives of leadership that each physician participates in, whether they acknowledge leading or not. They still do that. And I think it's really important. And I like what you said in your book about the idea of the leadership role, and to recognize and to actually encourage physicians to better understand and better undertake the idea of being leaders. And so putting that into that perspective, it's not only then telling me as a patient what I need to do and leading me through my process of implementing the treatment plan that I will participate in because of the leadership that you've provided, but also the leadership of the team. And and as we talked about a little while ago, that waste of time, if you don't engage that employee's brain, then you're really not leading. And what you should be trying to do is to get that employee to be more participative in what goes on and how that particular scenario works. So I think that physician's role is so critical in putting this together. But let me two other thoughts here. One is there's a little difference between, in my perspective, of what leadership is and what management is. And so when I look at leadership, to put it into a context from Peter Drucker's kind of world, is what he said. Leadership is doing the right thing. Managing is doing the thing right.
Yeah, I like that. Always
And
have.
so what you're looking at here is making sure, as a leader, as a physician, that this is the prescription, this is the procedure, this is that, telling the patient to do this, and so on. Taking the lead there, or working with the patient or working with the team and saying, help me do this. But then you go the next step, and without the follow through in the management component, either both by the patient or the team member, that the outcome is not quite what was expected. So we're looking at that. In preparation and then thinking about our discussion, I want to share a personal experience with you that might help identify that leadership role a little bit more and the management difference. A few months ago, and I'm violating HIPAA because I'm talking about my personal experience. How's that? So,
Well, as long as you're approving
Yeah.
it, then there's no violation. So
I think I'm safe that way. But a few months ago, I was diagnosed with something called giant cell arteritis, which had a It has a threat in terms of potential blindness if it's not dealt with. So, fortunately, I had a preventative medicine visit with my retinal surgeon because I've also had a detached retina. So every year I go see him. Well, when I saw him, he detected that I had had a stroke in one of my eyes. And so he sent me to my cardiologist, and he said, "If you don't see your cardiologist, I'm going to send you to the emergency room." I went to my
So no, I promise I'll see him. I don't want to go to the ER.
yeah. So I went to my cardiologist, who then said, "Hmm, a stroke issue. You need to see a neurologist." So I saw a neurologist. Well, the interesting thing is, I happen to be on traditional Medicare with a supplement, so I'm not in a Medicare Advantage plan. So I didn't need prior authorizations. So I went from my retinal specialist on Tuesday morning to my cardiologist on Tuesday afternoon to my neurologist on Wednesday afternoon.
Oh my goodness, that's a
And,
record.
well, how did that work? Well, talking about leadership here, the the retinal surgeon said, "You got to go do something." So he was taking the lead and pushing me to do something. Well, I knew from my experience with my cardiologist that if I called him, I'd be on hold for 20 minutes. I may or may not be able to get in to see him for another week, all that sort of stuff. I literally walked across the street, stood in front of the receptionist, and said, "I need to see the cardiologist." Fortunately, there was an opening that afternoon. No prior authorization and patient participation being pushed, taking a lead, if you will. The neurologist happens to be my neighbor. So I texted him and said, "I need to get in." And he then texted me back and said, "I can work you in tomorrow afternoon." Where I'm going then is what happened is the neurologist then sort of took over and ordered different tests, different procedures, and that sort of thing. Ended up having a biopsy that the neurologist coordinated within the system and that sort of thing. So the neurologist took the lead in managing my care. He then referred me to a rheumatologist who then is now, quote unquote, managing my care. So the rheumatologist I see her every month. I get I'm on certain medications and doing all that sort of stuff. My point in putting this exercise together is that without the leadership of any one of those steps, even the cardiologist, who was difficult to see because his office is a mess, he still said, "You need to do something else, and that's see a neurologist." So so we're not only just talking about how it flowed in an office, we're talking about how the whole system flowed to be able to give me the ability to be with you today and be able to see.
Yeah. No. That's great. And you bring up a very good point about also taking charge of your own health. And we certainly encourage patients to do that, as frustrating as some access to systems can be, being persistent when
Right.
it comes to taking care of yourself with all the other distractions that we all have in our lives. I'm overdue for not violating HIPAA because I'll have my own healthcare issue. But I have a small cyst in the thyroid, and I'm supposed to get it looked at every year with an ultrasound. And I think I'm at like 20 months, so I should probably go do that. You just reminded me. I need to
Maybe that's a good thing we had this conversation then.
push my own health here a little bit.
Yeah.
So I appreciate that.
But part of my point is that if you actually think about what each of those physicians did as I went through that process, they each took a lead in helping me be able to become, to be able to be able to see and be able to do those things. And had those physicians not taken the initiative to make the effort to lead in my care process, I don't know where I'd be.
Yeah. Yeah. Well, and a lot of its emphasis too. When we talk about leadership as a physician, it's convincing a patient to do something, to engage, to take medicines, to, stop smoking, lose weight. I believe it was Eisenhower, I should look this one up, that said that leadership is getting somebody to do something that they didn't want and want to do it. And so, saying this is why this is important and presenting that, I think, is a leadership event. You're attempting to influence someone's behavior to get them to do something that they wouldn't do on their own. Not necessarily that they don't want to, but you wouldn't do that unless somebody advised you and convinced you that's important. And I think the degree to which we communicate well, that we as physicians present a credible thought process. This is why I'm coming to this recommendation. This is why it's important for you, is all a function of that leadership, of influencing behavior.
And I could share with you, a couple of other scenarios. One of the groups that I worked with had a very interesting dynamic that they were involved with. There was an informal leader who had more influence than the elected leader in terms of how the group itself functioned. And this was a small group of like 15, so it wasn't huge. But the interesting thing was we get together once a month for our regular monthly meeting and so on, and the elected leader would conduct the business and that sort of thing. But you always knew that there was an undercurrent of what the informal leader wanted to do and what direction he was going to be recommending that the organization would go forward with. So just looking at how even groups function a little bit, at physician to physician, peer-to-peer kind of level, that there needs to be that respect, that trusting, that good communication, all of those kinds of things that you talk about in your book, and that I talk about a little bit as well, in terms of what is the function of the leader and how does all of that work? And then what influence does that leader have on the overall direction that the organization is moving forward with? And I thought that was an important point to bring up, that you not only look then at the formal leadership role, but that to recognize that there are contributors who are not elected, but have an influence that helps move either the group, the team, or the patient forward. So if we go back to that individual patient experience, even the medical assistant, that lowly little person, okay, not this big doctor person, but that medical assistant can have just as much influence on how well I participate in my treatment plan than the doctor can. So what does it need? It needs that doctor to be able to have that ability to recognize the talent and skills, keep that employee happy, do all those kinds of things, because that employee is contributing a significant amount of effort toward providing me as a patient that care that I need. So there's that whole concept that I think is really, really something that people need to recognize and be aware of.
Yeah, when you walk into a well-run practice where folks are competent and they're obviously caring and compassionate, you feel confident in the decisions and recommendations that you're hearing as well. If the patient flow is awry and you're waiting and nobody's talking to you, and then you get put in a room and nobody comes in, you think that at even a subconscious level, has to affect your willingness to engage in the plan, because you think, do these folks really even know what they're doing? And that's an important concept within leadership as well. Is one of the reasons that militaries the world over have drill and ceremony, is it just shows you that we have the discipline to be able to do complex things, which implies that we have the discipline to do other complex things, right?
I mean, you're right on, right there when you cited that kind of example as to what could happen. So it's like you've had some experiences with this.
Well, thank you for your service. I neglected to mention that earlier, and I truly appreciate it. Let's wrap up here for now. But coming up next time, Owen Dahl, author of Humanizing Lean Leadership in Healthcare, will discuss the critical role formal and informal leaders play in successfully implementing new programs.
When I end up with a set of recommendations and so on, I'm looking for that leadership, and then I'm looking for the opportunity to make sure that there's coaching, mentoring, and training that goes on that ensures that implementation will be done, rather than being, again, a dictator I want to be an engager, getting people to be able to do that. So in order to be assured that the recommendations that I make are implemented, I'm looking for that to be able to have happen.
This has been All Physicians Lead. We can all be better leaders, and our teammates and patients will be the beneficiaries. Go to allphysicianslead.com to unlock your potential, sharpen your impact, and elevate your journey. All Physicians Lead with Dr. Leon Morse is a production of Forbes Books.